Hello everyone, this is Dr. Khan, Executive Plastic Surgery. A warm welcome to the new members to the Facebook group page, and warm welcome to anyone who's listening, any significant others, spouses, the many patients who are listening, and we'll be discussing what is a very important topic, what is breast implant illness, how I see it as a plastic surgeon. My practice is exclusively devoted to what is explant surgery, that is removal of saline implants, silicone implants, and residual capsules. I want to go ahead and invite my guests to the YouTube channel, and over the last 3-4 weeks we have added a lot of videos directly from the operating room where you will see the dissection in itself done on the chest, and you will see the entire dissection, on some cases residual capsules. You will see the many patients that I've operated on. You will see the overwhelming majority theme, which is where the blood loss is going to be less than 5 cc's on each side. You will see the videos, high definition pictures of complete total removal of the capsule, plus that inflamed tissue, and all of that fascia of the serratus anterior, fascia of the pectoralis minor, the fascia of the pectoralis major, along with the periosteum, perichondrium, and certainly the fascia of the intercostal muscle that is definitively 100% sincerely, honestly, religiously removed, such that the patients have the best benefit of what is this explant surgery. And so I want you to please go to that YouTube channel, which is the Khan Plastic Surgery breast implant illness page. I will go ahead and send this on a link. If you go to my webpage, executiveplasticsurgeon.com, you will see that YouTube videos that we have uploaded over the last several weeks, so you can see firsthand. Now, this is what has been the recurrent theme from the beginning of the year. You want to go to a surgeon who is 100% a firm believer in what is breast implant illness. You want to go to a surgeon who is very transparent, who shares with you these videos and also the high definition pictures, not only of the chest wall, but also cutting open of the capsule on the table with the patient's initials, using sterile gloves so that you're not using non-sterile gloves in case there's any fluid, anything that may need to be sampled in between the implant and the capsule, such that you have complete transparency. And in my practice, as you will see, the whole commitment is made to the capsule. Anyone can remove the implants, but it's all about that commitment, that serious, religious, honest, respectful commitment to removing the whole capsule, such that when the surgery is done, number one, all of that capsular tissue, inflamed tissue, and implant is removed, preferably as that en bloc system where there is no breaks in the capsule. And number two, all what is removed is then also tested by the pathologist to make sure that there is no lymphoma. That very rare BIALCL CD30 analysis is done, ruling out the squamous cell cancer, which is very rare of rare, but still ruling out the breast cancer, among other problems, so that you have the peace of mind that, number one, all of it, i.e. the inflamed tissue capsule was removed, and number two, all of it was tested, so you have the peace of mind that there are no surprises awaiting you in the future. Now, in my practice, as you will see, I have my own way of doing it. This is the only surgery that I do primarily, which is removal of the saline implants, silicone implants, and residual capsules, and the patients come to me from far away. 9 out of 10 patients, if you will, travel to see me, and this is where patients have made it from Europe, from Africa, from the Middle East, certainly from North America, Canada, Mexico, and amongst the other areas. And again, this is where I have done it consistently, where I have my own way of doing it, which is called the Khan procedure. One of the patients actually did go to AI, artificial intelligence, and they did on Google type in the Khan procedure, and you can actually Google it, the Khan procedure, and you will see an AI generated list of what it entails. And as you will see, number one, no drains required. I've not placed drains in well over 5 years. Number two, I do not do the unnecessary lift, because the majority of the patients, the lifts are not required. Certainly there are patients who are candidates for a lift, but this may not, and this is not the right time to be doing a lift. I've done lifts on many patients, but I do not offer them routinely. So number 3, I return the implants to the patient so that the patients have a psychological closure as to what was inside them. There have been many instances where the patients have opted for saline implants and they got silicone, or vice versa, or one was saline, the other one silicone. One was one brand, the other one was a different brand. Also, number 4, I take high definition pictures and videos, and as mentioned earlier, where the patients can see not only of the chest wall, which is the most important picture, and the video that basically shows that complete total capsule removal was done, and also on the table where the cutting open of the capsule was done with the patient's initials and date of the surgery highlighted. Number 5, I basically do what is twilight deep sedation, where the patients the general anesthesia is where the patients are paralyzed and an endotracheal tube is put in and the ventilator essentially breathes for the patient. This is very safe, done routinely every day. But in my practice, what I offer is the propofol, fentanyl, Versed, what is IV deep sedation, where the patient is completely amnestic to the event. There is no breathing tube, and the patients are breathing comfortably, and they have no recollection. As you will see, not a single patient to date has any recollection of the surgery. And so the other thing here is I take cultures for aerobic, anaerobic, and fungal. That's item number 6, so that I send it off to microbiology lab, so we know that if there is a bacterial burden or colonization, which does occur in 10-15% of the time, that we basically know if there was a bacteria involved in the biofilm around the implant and within the implant and capsule interface. And last but not least, all the patients, regardless of their age, get the same surgery. As you have seen the Facebook Lives that I've done from the hospital on the 85-year-old patient who had the 750cc implant, I removed hers in a similar fashion that I do the other many ladies in their 30s and 40s, and I do not compromise a person's surgery because of their age or comorbidities. If the patient has illnesses like COPD or underlying physiologic state where they may need to be done at the hospital, or if it crosses my mind, I certainly do go to the hospital so the patient has their best benefit for outcome, and this is the right appropriate setting for them for what is outpatient surgery. Now I want to go ahead and request my listeners to ask any questions you may have. This is your chance. Please ask me any questions, and my job right now today is to answer those questions to the best of my ability, and so that do you have any questions? So one of the other questions that came up today was, do I mandate an MRI? Now, if you look at the manufacturer's warnings, and this is the Mentor advertisement itself. As you can see, they're advertising the Mentor ad, the implant. And then at the bottom, I'm going to go ahead and read right here verbatim. Quote, MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture. So, which basically means that the manufacturer is telling you if you have a set of implants. So today a lady came to me, she had implants from 9 years. So she should have, according to the guidelines, gotten her MRI at year 3, at year 5, so that's her second one, at year 7 and year 9. So she should have had 4 MRIs. Now, I do not mandate that, it is going to be too costly for the patients. And again, the manufacturers are doing this in order to protect themselves. So in my case, if a patient has had a history of a ruptured silicone implant and now a second set was placed and the patient has had history of free-floating silicone, I want to see if there's any pockets of silicone that were basically silicone granuloma, silicone masses that were left behind by the previous surgeon because it was not adequately cleaned out. Unfortunately, many surgeons believe, so what that the silicone spills into the chest, we will wash it out, we'll put a drain. No, it is incomplete and wrong, and if you ask me, in my practice, inadequate and not right and not healthy to allow silicone to spill into the chest, because once that slime, i.e., if you will, that silicone spills into the chest, then it's going to be a continued misery, and silicone toxicity will inevitably continue to occur because it's going to be bathing the tissues, and we see the silicone in the lymph nodes. So this is the whole purpose behind doing the MRI, And the whole purpose behind doing the end block so that I can identify any pockets of silicone that might be present, that might be walled off and suture secured shut, so that now the patient may have ended up getting a mastopexy, so I can identify those pockets via the MRI, which I would not necessarily be able to palpate because it was walled off by the surgeon using suture. Now, in patients who have saline implants, I don't require a MRI or any imaging because saline implants are like water balloon. I do not need to get imaging. So again, in a very small subset select of patients, I do require the MRI so that as I go into the case, if there's any pockets of silicone, I may identify them and I will have a roadmap as to where they are located. And it is only in these group of patients. I always assume that the implants are ruptured till proven otherwise because I do not want to go in and find out that the MRI was wrong, which has happened many times before, where the MRI said that the implant was intact and it indeed turned out to be ruptured, or vice versa. So hopefully that answers the question.
I have another question.
Yes.
From a patient from Instagram. She says, I'm 5 months out from surgery. Do I have any limitations? Is there any way at this point I could do harm to the surgery? I'm assuming she had Explant. She doesn't specify.
So a majority of the cases, the implants are put below the muscle. And below the muscle means directly on top of the rib. And so the dissection is very tenuous and very meticulous and very involved and significant. This is where if you ask 10 plastic surgeons to do an explant below the muscle, 9 out of 10, if not all 10, will feel very uncomfortable and not want to do it. Now, in the case of the muscle is going to settle back onto the ribs and onto the pectoralis minor because this is the level. You have the ribs, if you can imagine my fingers. Then you have what is the pectoralis minor right on top on a small section of the chest, and then you have the pectoralis major that's sitting right on top of the ribs on top of the pectoralis minor. Now that pectoralis minor needs to eventually stick back, adhere right back onto the ribs. That process in itself may take 3, 4, 5, 6 months, up to a year, year and a half. So there was a patient that was lifting a couch. Now she was not a big lady and she was lifting a relatively heavy couch, which she should not be doing regardless of her surgery, and she ended up pulling a muscle. So you want to be very careful. Now, I tell my patients it's not recommended but required on average at week 6, week 7, week 8, depending on one patient to the next, and I direct this. I tell the patients to get some 2-pound weights, and they stick with the 2-pound weights for 3 months. And they build not only the biceps, but the triceps, the pec major, pec minor, the serratus, the deltoid, the suprainfraspinatus, the muscles of the neck, back, shoulder. And daily exercise, starting off with 1 minute 2 times per day, the second week 2 minutes 2 times per day, third week 3 minutes 3 times per day. Fourth week, you're going up to 5 minutes 3 times per day. So you're now actively building the muscle masses to your chest, neck, back, shoulder, which were truly compromised when you had your implants. You will see after 1, 2, 3 months, you would have built enough muscle mass to the point where you're now, quote, in a sense, protected. So I find my patients at month 5, because they're still actively working out, and remember this is a requirement, you will see that you will certainly indeed have built the muscle. Now, would you have plateaued and normalized and equilibrated? No, some patients are still recovering and improving and building on their muscle mass at month 5, 6, 7, depending on their exercise regimen. So I ask you, how comfortable do you move? Your range of motion should be excellent. You should be actively be swimming, and you should be actively working out in the gym so that you're building all of those muscle groups of the neck, back, shoulder. As you will see, that 5, 10, 15, 20% muscle mass you add to your chest will also add volume to your chest and to your breast tissue as well. Now, I'm going to go ahead and scroll through the questions. And I went to a consult, and the doctor said my implant is flat at nipple and my skin is very thin. Does this mean the end result will be very saggy? My implants, 350 cc's if removed. Now remember, if you look at the anatomy, you have nipple areola at the very top, you have breast tissue, you have the pectoralis major, you have the implant, and you have the ribs at that very level bottom, if you will. And that's the stage. Again, nipple, breast tissue, pectoralis major, implant, if the implant is below the muscle, and then the rib. Now, when I make the incision, and I make the incision that's going to hide right in the inframammary crease, I'm always below the muscle. Below the muscle, I do not touch the breast tissue. That's why I don't make any vertical cuts. I do not make cuts around the nipple areola. I only make the horizontal cut. And I'm always below the muscle. So whatever volume the patient has to begin with when they were in their teens, 20s, 30s, when they got, that is the breast tissue volume that they're going to have. When I go in, I only remove, and I'm only interested in removing the implant, the capsule, and as a result, that inflammation that's around the implant is also by default removed. So physically, when the patient gets surgery with me, they relieve, or they basically have 3 volumes that are removed. Number 1, the volume of the implant, the volume of the capsule, and number 3, the inflammation that is present on the chest. You see those dilated veins or the swelling that's present, that will diminish. And that is all done below the level of the muscle. So I don't touch the breast tissue. And also, I measure the distance from the nipple all the way down to the inframammary crease on the right, and also on the left down to the millimeter, so I match both the 2 sides, which majority of the times they're not symmetric to begin with. One patient may have a rupture or a contracture, or one may be larger than the other, or one may be malpositioned compared to the other. One may have history of multiple implants on one side versus the other. One may have had radiation, things like that. So I measure and I quantify. Now, if you were a cup A to begin with before your surgery, you're going to very likely end up being cup A, because I'm not touching the breast tissue. This is why I can operate on patients that are actively nursing, because I don't touch the breast tissue. I do not need to touch the breast tissue. I do not want to cut into the breast tissue, because you will get scarring, you will have ducts, nerves involved. And when you do your self-monthly breast exam, I don't want any scar tissue within the breast tissue itself basically becoming a area of concern on a mammogram or on a self-monthly breast exam. So I do not cut into the breast tissue. I do not make any up and down cuts or cuts around the nipple areola. So that's why I'm very careful. So if you have between me removing the excess skin, between me putting the internal sutures that help pull the breast tissue up, between the implant being gone that is pulling and gravitating the breast tissue down, between the swelling and the inflammation subsiding, between the recoil of the skin and the breast tissue, and lastly, between the 5, 10, 15% muscle mass that the patient adds to their chest breast area because of working out, you will see most of the patients are aesthetically very happy and satisfied with how they look, and their breast tissue is not necessarily saggy. Now, if someone has an 800cc implant, her tissue is certainly very much going to be expanded, and she's going to certainly have more sagginess, and there are patients who clearly are candidates for that. Now, having said this, if you go back and look at my Facebook page, you will see many patients who are in the 600, 500 range, 750 range, young ladies in their 30s. They did not need that formal lift because their tissue was able to recoil also well on their own. The other thing that I must mention happens when you have a large implant, or if a patient has a capsular contracture, the implant is sitting on the rib contours into a deformity where there is a concavity of the rib. Now, with the implant gone, the ribs normalize and that concavity is no more. So over the next several months and up to a year, year and a half, as the remodeling is occurring, that concavity is addressed, and now the patient does not have basically a concavity of the breast tissue, and now the breast tissue basically falls out. The other thing to mention here again is when someone has an implant in the proximity of the breast tissue starts atrophying. So it's just the sheer mechanical presence of the implant, and the presence of the breast tissue causes the breast tissue's volume to decrease, to diminish. And with the implant gone, the breast tissue now has a chance to expand, and so it basically does somewhat fluff out. And so these are the multiple forces plus the inflammation that the body goes through in order to recover. Now, most of the pictures, so one of the patients that came today on my Monday clinic, she was mentioning, well, if you look at your pictures, some of them are not the best. Now, I want to go ahead and expand on this right now and take this chance. There are surgeons who have gone through 200, 300, 500 explants of theirs and chosen the best pictures, the 7, 8, 9, 10 best pictures. They have chosen the best results, sometimes photoshopped, and they've posted their results, which is basically misleading the next patient because you are now fooled, gullible enough to accept, and I would too, because I'm looking for good results on a surgeon's website. So you want to be very careful. In my practice, you will see majority of the results are 3 weeks, 1 week, 6 weeks out. And if you want to see the results, you want to see the results a year and a half out. So those patients, for example, that deliver a baby, for example, if you see them a month out, their belly is all flabby and then there's all that relaxed tone and the skin is stretched out. But you see the same patient a year out, when I do tell them that you do not need a tummy tuck, a year out they never come back because their body has normalized. So likewise, in a similar fashion, the skin and the breast tissue has a recoil. And the younger the patient, the more the recoil, the more taut the breast tissue. So as a burn surgeon, if I have removed 10 centimeters of full thickness skin from a patient from the thigh, for example, to as a donor site from the thigh, I find when I put that 10 centimeter long skin on the table, it becomes 6 centimeters. So by 40% is what the skin shrinks. Now, sometimes if a patient is older, postmenopausal, the elasticity of the skin has gone down. Someone who's on steroids, her elasticity of the skin has gone down. Someone who has a lot of sun damage, elasticity has gone down. Someone who's been drinking heavily every day for the for the last several years, their elasticity of the skin has gone down. Sometimes with patients who have poor quality genetic skin, that skin is going to be certainly irritated. Someone who has radiated skin, so I took care of a patient who had radiation of her breast after a lumpectomy and radiation. Her skin quality is very different compared to the other normal side because it is very inelastic. So there are many other factors that come into play, as far as the recovery of the patient. And this is where I find in my practice, 80% of the patients do not need that unnecessary lift. And going back to the pictures, you want to see the pictures a year and a half out. The other thing I want to mention, one of my patients, and I talk to my patients and my patients tell me, she saw a set of pictures of a patient's results on a surgeon's website, and when she was surfing another surgeon's website in another state, she saw the same set of pictures in another surgeon's website. And these are called model patients, which means that when you make a website, you can get these model patients, and at the very bottom write down, these are model patients, these are not my results. And so you have to be very careful with what you see, because when you see these pictures that are posted, all of the intent and purpose here is to lure you in and to saying, oh, well, this person has excellent results, excellent pictures. In my practice, I show that whatever the next patient's pictures are, I mentioned 650 cc ruptured implant, 650 above the muscle ruptured implant, or 800 cc. So I'm very direct and blunt, and I want to show my patients what the findings are, because each patient has some story going on, or be it a ruptured implant, be it a malposition, be it a double bubble deformity, be it 5, 6, 7 sets of implants, be it radiation, be it large implants, be it done by a surgeon who was not board certified or an incompetent surgeon. Believe it or not, today I saw a patient who was operated on by a non-board certified surgeon, and you can imagine that the results of that patient are very different compared to another board certified plastic surgeon. So all of this needs to be factored in. So hopefully that answers your question. So if you were, now the other thing I want you to know is when you were in your 20s, 30s, when you got your implants, you will never be going back to looking like when you're 20, 30. When you're postmenopausal, for example, the amount of breast tissue becomes less. Ultimately, the breast tissue gets replaced with fatty tissue because there is no hormonal influence by estrogen, progesterone, and so the amount and density of the breast tissue gets less and less. So you have to factor that in as well as you get your 350cc implants removed. So I know that was a handful, but if you go back and listen to this, what I'm trying to say is there are forces from the surgeon's ability to operate, how good he or she was, what the effect of the implants and the inflammation that the implants caused, what was the position of the implants when they were placed, and how and when they were removed. Majority of the implants, when they do start off, they're in the upper part of the chest, and over time they only bottom downward and outward because of the malpositioning that sometimes occurs. And so there are so many factors that come into play. In my practice, I measure the distance from the nipple down to the crease on both, so that once I remove the implants in the en bloc fashion or 100% total capsulectomy, that I basically match the two sides so the patient has the best aesthetic result that she can get. And most of the patients are very happy and satisfied. Now, what one needs to do is you need to go to and talk to your own plastic surgeon. How many times do I hear a patient said, well, I talked to the nurse. Well, the nurse is not operating on you, or the physician assistant, or the nurse practitioner, or the medical assistant, or the resident, or the fellow. No, the surgeon is doing the surgery. You need to talk to the surgeon. You need to spend time with the surgeon understanding his or her psyche. One of the patients that came to me, she came to me from far away. She's going to be scheduled for her surgery, and she said, I feel like I already know you. You need to understand your surgeon's psyche, because remember, this surgery is all about respect, i.e., that the surgeon has for you. Number one, that your surgeon understands and respects that breast implant illness indeed exists. I did a phone consult earlier this morning, and the patient said that the surgeon did not believe in breast implant illness, but he said, well, I will remove the capsule, but I don't believe in it. You've been watching so much social media, and if you want me, I will go ahead and do that. And the surgeon is just saying it because he does not want to, unfortunately, lose that patient. And the surgeon should and must be completely 100% wholeheartedly committed to removing the whole capsule, because post-op you do not want to second guess your surgeon. You want to have that peace of mind and confidence. Number one, your surgeon got it all out. Your surgeon has a track record of getting it all out, and your surgeon is going to prove in the videos and the pictures that all of it was removed, and the surgeon has been checked and verified. Not only I, but all surgeons, so that you have seen the high-definition pictures, videos of the chest wall. How many times do I see that the surgeons are fixated on a lift, on drains, and if you see between the fat grafting, their surgery is done in 2.5 hours, where I take 4 hours on average to remove what are 350cc implants in a manner that I described earlier. Is it that am I slow, or they're too fast? And deep down within, if you look and see, there is no proof as far as high definition pictures, videos of the total capsule being removed or having been removed, and that there's fixation on the aesthetics, fat grafting, there's fixation on the lift. That in itself takes 2.5, 3 hours at least. So where and how the en bloc occurred on itself is beyond me. So you want to make sure you do your homework. So the many lifts that I have done in the patients, I have spent almost 4 hours plus minus doing the en bloc or a total capsulectomy, which is a very tedious operation. And I have spent almost 3 hours or so doing a lift, which is a separate case. Remember, the lift or the mastopexy is at the surface, at the very top, at the skin level, and the explant is at the rib level. These are two separate procedures, even though it's the same region, the breast. Now, when can someone swim, breaststroke, or backstroke after en bloc? Now, this is when you have been doing your exercises, your range of motion is good. So let me go ahead and kind of go over, this was one of the questions asked earlier today, how free am I going to be after? So those patients where the implants are above the muscle, their recovery is better, smoother, and these are your average size implants. So if someone who has 800cc implants, her surgery, her recovery is going to be longer. So if the average patient who has 400 cc implants, 350, 400 below the muscle, and the dissection was done directly on top of the rib, you will see, let's say if the surgery is done today, tomorrow I can type, text, I can make myself a cup of coffee, a sandwich, but I cannot lift a gallon of milk because you will inevitably end up using your pectoralis major. At a week's time, when you're off your pain meds and your reaction time is good and you're comfortable and you're confident, you can be driving. And so this is where instead of 10 to 2, 9 to 3, you're driving, and you're driving with comfort and with confidence. One of the patients said, well, I feel uncomfortable. I said, then don't drive. So it's a patient discretion. It is totally the patient's responsibility. If you have a desk job, week 2, week 3, you're pretty much moving your digits and you're picking up the phone and talking, so you would be able to very well go back to your work at week 2, week 3. Now, if you are a nurse or you work as a flight attendant or you're an engineer, you're climbing up and down the stairs, or you work at Amazon lifting heavy boxes, for example, or you're a hair salon stylist where you're using your arms all day, in that case, you're looking at 8-10 weeks before you can return safely, and then still in a very limited, very guarded way, because you do not want to disturb whatever the chest was. And the patients will be wearing the bra and the binder, which is very much part of any plastic surgery routine. So if you get a tummy tuck, you're wearing a garment from your upper chest all the way down to your mid-thigh for 6 weeks at least. So in a similar fashion, the patients are wearing the bra and the binder, and they're very controlled and limited in their movement because you do not want to be moving the muscle. And the muscle, the pectoralis major, inserts into the upper arm, the humerus. So for that reason, let's say, for example, if you're moving, making a cup of coffee and drinking it, a sandwich, and you're picking up the phone, that's very safe because you're not moving your arms. So you are very guarded. Now, if you're moving your arms and hanging your coat and lifting heavy patients or objects, then you're inevitably ending up moving your pectoralis major, which will end up hurting you. So just like after any surgery, your post-operative recovery is dependent on your compliance. And I tell my patients the safest and the best thing to do is to put a tie around, like a scarf around your arms, so you're not moving your arms, because you will inevitably end up moving your arms. You've been moving your arms your whole life, and you will have a tendency. So today, one of my patients from Thursday, she came in and she's like, I'm not even taking the Tylenol, I'm not in any pain, and I'm moving my arms around because it doesn't hurt. I said, that's not a reason to move your arms around because it doesn't hurt. You cannot move your arms around because you just had what is very involved surgery. And I showed her the high definition pictures and videos of the chest wall, and when she saw that big area that I dissected into, she truly comprehended the fact that you could not and do not want to take any chances.
I have a question.
Yes, please.
One patient asked what happens when a breast implant breaks.
So what happens when the breast implant breaks? Now you have to ask yourself, is it saline or is it silicone? So saline implants are like a water balloon. They completely collapse, or like an IV bag, if you will, and you will see an instant, very dramatic, significant volume drop on that one side compared to the other. Silicone implants, believe it or not, just like I read earlier, and I'm going to go ahead and read this again, MRI screenings are recommended, quote, MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture. This is on the Mentor advertisement on the back of a journal. I basically made a copy and laminated this. Silent rupture. Silent rupture means there are many patients that I have seen, if you examine them, they look good, normal exam, nothing out of the ordinary, and lo and behold, I go in to remove the implant, and to my surprise, to the patient's surprise, the implant is ruptured, which is called a silent rupture, and majority of the ruptures are silent. And so this is where nothing will happen. There are some patients that have come to me where this young mom was hugging her 4-year-old child, and the child came close and all of a sudden quickly jerked the knee up and hit the breast tissue hard. She said, ever since that time, my left breast implant has been hurting, and lo and behold, we got the MRI and it shows a rupture. So there is a direct cause and effect. Or a car accident, the patient was wearing a seat belt, it spun on ice and ended up in the ditch, and the next thing you know, she hit and the seat belt held and the airbags deployed, and she had trauma. Now remember, we're always in one way, shape, or form traumatizing our chest. If you're standing outside on a windy day and the car door swings open and hits your side, or someone riding a bike got hit by another bike on the side and now there is pain, or another patient that fell at her workplace because of the ice, and lo and behold, she now has pain. So a workup would entail getting an MRI. Now, the bottom line here is majority of the times it's a silent rupture. So with the silicone implants, you will not know what happened in majority of the times, and that's why the MRI becomes key in order to look for what is a silent rupture.
I have another question, Dr. Khan.
Yes.
Is it normal for expanders to feel like they are in your armpit?
So believe it or not, sometimes depending on the surgeon, when there is capsular contracture, where the implant, in this case the tissue expander, forms a capsule, that may get pushed up into the side because that may be the path of least resistance. And so you may feel that the implant is, quote, pushed to the side or being pushed up to your upper part of the chest, and it becomes firm and hard. So, now, there are times where the implants were placed through the armpit, and so that was the pocket that was made. And because the pocket was made there, the implants have a tendency to fall into that pocket because that's where the dissection occurred. Capsular contracture can cause that, malpositioning can cause that. Now, if you can imagine those many ladies who have had no implants, and you tighten, or a bodybuilder tightens or lifts 200 pounds, you're going to tighten the pectoralis major with respect to the rib, correct? Because that is where the pectoralis major is going to sit against. Now, if you have an implant below the pectoralis major and you lift up 50 pounds, 70 pounds, or you lift up a bag, 35 pounds, you're going to the airport, you will compress that implant against your rib, and it will be an awkward feeling. Sometimes the implant will bounce around. So just like a male bodybuilder on the stage and he flexes his pecs and you see the pecs bounce up and down, some ladies have what is this animation deformity, where when they flex their pec, they bounce the implant up and down. And so this is a very awkward feeling. So the ladies work around. And so those patients that have had implants cut below, where the implants were placed below the muscle was cut, and the implant was indeed put below the muscle, and now the muscle in itself gets compromised. Imagine the implant was placed below your thigh muscle, and I asked you to run. Your muscle on your thigh would press against the long bone, the femur, and the implant may move up and down. It may be an awkward feeling because now the implant is getting in the way. So your athletic ability, your neck back pain may get worse or may come out because of the malposition or position of the implant, and it may certainly indeed right into the axillary area. Majority of the times what happens is this: if this is the pectoralis major and the muscle is cut at the bottom, the implant, if this is my fist, is the implant gets placed underneath. So now I'm going to go move this mic out of the way. So if you have, this is the pec major muscle, and you cut the muscle underneath in order to put the implant underneath. So what happens is the muscle is not brought down and sutured, secured back to the origin. So what happens is the implant's kind of hanging down, and over time it just gravitates down. Now when you squeeze and tighten your muscle, the muscle squeezes this implant downward and outward. So you'll see majority of the implants are essentially bottoming downward and outward, and they malposition and they run into the armpit for that reason. And that is also very, very common, you will see. And so this is why the plastic surgeons got together and they came up with what is Galaflex, which is a mesh that they put at the bottom to prevent the implant from falling downward and outward. This is why the breast cancer patients, usually they have the larger implants, 600-800 cc's. They have alloderm in their reconstruction so as to hold the relatively heavy implant in place. Insurance pays for the alloderm, and that's why the alloderm is usually used a good number of the times in breast reconstruction in those patients who have had breast cancer. So I see now the many times I get asked, well, I don't want to travel, it's too far. I'm in California, I'm looking for a local plastic surgeon, I will tell you, you need to have that firm commitment from your plastic surgeon that he or she has a reputation of removing the whole capsule. She is going to give you the videos and high definition pictures of not only the chest wall but cutting open of the capsule on the table with sterile gloves so that you know exactly how and what the capsule was removed with your initials and the date of the surgery so you know it was you. You need to have basically that absolute firm commitment that your surgeon is a firm believer. If you ask me, majority of the plastic surgeons do not want to even hear the word breast implant unless you should go to your plastic surgeon telling them that you want a replacement, and they should themselves stop you and say, oh, well, I only do explants and I do them in the manner, then that's your surgeon. You should tell them that you do not want the capsule removed and see what their reaction is, and you will get the answer that, okay, no problem, because majority of the plastic surgeons are just accommodating and giving into their patients' requests because they don't want to lose the patient. You want to have a surgeon who's wholly committed to removing the capsule plus the implant and getting it tested. So there are many patients that have come to me and they said they wanted a replacement, and I said absolutely not. I only remove, and when I do remove, I remove the capsule as well completely, sincerely below the muscle so that you get the entire capsule removed right. So one of the other questions that I got asked was, you know, is it safe for me to travel? Well, I will tell you, vast majority of the patients have traveled to me from all over the US, all over the world, and it is very safe and healthy to travel. The risk for the clot or the DVT, deep vein thrombus, is essentially minimal to none and non-existent. I give every patient heparin 5000 sub-Q at the start of the case. Number 2, I have all my patients wear compression socks. Number 3, every patient gets the SCD boots, which are the sequential compression devices. Number 4, I do what is twilight deep sedation, where the patients are not paralyzed and the ventilator is not breathing, so the patients are able to maintain their muscle tone and no risk for blood pooling. Number 5, I mandate that the patients on the day of the surgery are out of bed to chair, and the following day walking and ambulating gently. Nothing that's going to up their heart rate. The only activity you're allowed is walking gently so that your bowel pattern comes back, your breathing is better, and that you have essentially no chance for getting a clot just like you did the day before. So hopefully that helps. Now, any other questions that anyone can think of?
A couple, Dr. Khan.
Yes, just a second. So I tell my patients, do your homework, do your research. You're going to feel that mental satisfaction, that mental contentment from your heart, and you will know from your mind and from your inner soul that you're making the right move. You will, as you will see, this is a surgery where, if not all, the patients have said two things. Number 1, they wish they had never gotten implants, and number 2, they wish they had gotten them removed sooner. Yes, Mar, please, if you can tell me the questions.
My surgeon removed the entire capsule and repaired my muscles. Some will not repair muscle. Why is that?
So it depends on how your initial surgeon cut the muscle. If you have a 600 cc implant and you're small chested and your surgeon cut the muscle and the muscle is retracted all the way up, the muscle cannot be repaired. I find some surgeons are cutting from the nipple all the way down. As they do so, they cut through the muscle, and now they're cutting the muscle that they themselves cut. Now, as far as so this is, you have to ask. So today I saw a patient of mine. I repaired her muscle, and I absolutely 100% repaired the muscle. And again, this is a very much honor code. I've done it on my breast cancer patients. I've done it on my cosmetic patients, depending on how your initial surgeon did the surgery and how, quote, professional and good and sophisticated he was in order to cut the muscle as he or she put the implant below the muscle. Sometimes, no matter what, the muscle window shades up and it atrophies, and no matter what, you cannot pull the muscle down and repair it simply because it was not done right to begin with. And unfortunately, there's a lot of, quote, damage control with that. So it is not, it is patient dependent on how the previous surgeon in my practice, how the previous surgeon cut the muscle and what the status of the muscle is. The muscle absolutely needs to be repaired for two reasons. Number one, for function, so that you get good function out of that muscle. And number two, you want to be able to aesthetically add to the chest and the breast. Those patients that have had their muscle repaired certainly have a better aesthetic result than those patients where the muscle was not repaired. Now, if you can imagine, if someone cuts the Achilles tendon, just for discussion purposes, the Achilles tendon, the muscle is going to retract up. 3-6 months later, you cannot take that muscle and move it down and anchor it back to the sole of the foot. In a similar fashion, the muscle does atrophy, it does weaken, and because of the nature of the way the muscle is cut, it contracts. And how much of the muscle was cut and the way it contracts, you cannot take that muscle and suture it back to its origin where it was anatomically.
I have another one.
Yes, please.
My left breast developed capsular contracture not even a year ago out from surgery, and my right is okay besides itchy and red bumps on the side. Is that a common side effect?
So capsular contracture occurs 10% depending on what literature you read, and majority of the times we do not know. So this is the 4 grades of capsular contracture, what they call Baker's classification. And so the capsular contracture can occur soon after placement of the implant, or it can occur a year later, or 7 years, 10 years, 15 years later out of the blue from nowhere, and where the patient was fine for all those years. So we do not know why it occurs. Now, there has been reports and studies that have been done which show that if the implant is above the muscle, higher chance for capsular contracture. Bigger the implant, higher the chance. Repetitive motion, trauma, whatnot else will do it. There is also a bacterial burden biofilm thought that may account for formation of what is capsular contracture, and which is very interesting because the one side is normal, healthy, good, normal appearing, and the other side is very hard and rigid. And when it becomes so hard and it causes pain, which is called that grade 4 capsular contracture, there is what is breast is deformed and painful, implant is palpable and visible, which is the highest of its kind, and especially if it's impinging on a nerve. But if there is no pain, then that is called grade 3 capsular contracture, where the breast is hardened and implant is palpable and visible. So that can occur. Now, sometimes the surgeons will give you a medication. It's a side effect where it breaks down. It's an asthma medication. It breaks down the capsule and makes it less rigid. Sometimes the surgeon will press hard, what they call is a closed capsulotomy, for managing and breaking down the scar tissue. And it's a very uncomfortable feeling because it's hard and the surgeon is pressing very hard in order to break that scar. Sometimes you have to do this in the operating room while the patient is asleep, and sometimes you have to go back in and you have to score, which means cut the capsule open, and so now that scar is essentially released. Now, from my experience, I find that if a capsular contracture occurs once, it is an extremely high chance, inevitably, it will occur again, because the body's already done it once, it will do it again. So some surgeons try to put alloderm, cadaveric skin. Now, the bottom line is sometimes I say this is what is a losing battle, because the capsular contracture is a very unsightly. Number 2, it shows that the breast is deformed, it's very hard, and sometimes painful if it is in the proximity of nerve. And you have to go seek consultation from a board-certified plastic surgeon so that you get the treatment that you need. Believe it or not, sometimes in select few cases, there might be suggestion that there might potentially be a rupture. Does not mean it's a rupture, but as you can imagine, it is so hard, it will put undue pressure on the implant and may cause it to rupture. There are many patients that I have taken care of with capsular contracture, and the implant was fine, it was not ruptured. So there is no necessarily correlation between the two. You should seek, it is not normal to have and live with capsular contracture, so you should seek consultation from a board-certified plastic surgeon to address this definitively. If you go back and look 3 years ago, I did take care of a patient who had capsular contracture multiple times, and believe it or not, she had well over 15 surgeries. And I told her, even if you did another 15 more, the capsular contracture would keep coming back. So you want to define what is the upper limit of normal. You may want to go back 3.5 years and listen to the nice lady that came from Windsor, Canada, and you will hear from her own words the many surgeries that she had in order to correct what is the capsular contracture.
I have one more question, Dr. Khan.
Yes, please.
When can I go swimming post-explant in drains?
In drains?
So she must have had her surgery with a different surgeon.
So I will tell you, having drains is, remember, a drain is the tubing that goes inside to the chest. So there is a window, because there are some drains that will leak around the drain site, even though it's sutured in. Now, you do not want to go swimming and the next thing you know, that chlorinated water, non-sterile water, it's not even saline, it's chlorinated water. It's with all those chemicals, it may have a potential to go back into and backseed, or it may fill that JP's bulb reservoir, or it may backtrack into, because the drain might work as a seeding agent of that fluid. Remember, water is very smart. Just like it leaks through the roof, it will leak and go backtrack through the drain and inside, and that may be a catastrophe. So you need to talk to your surgeon directly. And in my practice, with the many drains that I have placed for other reasons, I did place drains in patients with a ruptured silicone implant that came to me with free-floating silicone, so I placed drains in her. I would never let her swim. I would absolutely not let her get in and around the water, because I don't want that water to be smart enough and to find a way into the chest cavity, and that will be a major catastrophe to manage. The drains have a role and a purpose. Now, let me go ahead and answer this question. I've been asked many times by many plastic surgeons and many doctors as well, and many patients, as to why I don't use drains. Number one, drains are not required. A couple of years ago, in May of 2023, I presented at the world's largest plastic surgery conference, my 1,000 explants, and I said I only needed drains in 7 patients, period, out of the 1,000. And the last time I myself used drains was well over 5 years ago, even with the many ruptured implants, large implants, a lot of inflamed implants, because I'm removing all of the bad tissue. I'm removing all the inflamed tissue. I'm never letting silicone spill into the chest. I'm removing all of the capsular tissue, and only good, healthy, viable tissue remains behind. And the blood loss in well over 99.7%, if not more, of the patients is less than 5 cc's, and there is no indication for the drain whatsoever. Conversely, my patients don't go on Facebook or YouTube or go to their local doctors and get drains, because they are not required. Now, what is the requirement for the drain? So in those 7 patients where I used the drains, one patient, the 81-year-old that came in, was in a car accident and the car spun on ice, and she had silicone that was free floating. A month later, referred to me by the trauma surgeon, and the MRI showed free floating silicone in her whole chest. So as soon as I made cut, there was silicone pouring out. So in her, I automatically put in the drain, because she is a candidate for a drain. No matter how much I was going to do, I was not going to be able to do an end block on her, because this was an extra capsular spread. The other patient that came in, where her 4-year-old boy kind of knee kicked her in the left breast implant, and as soon as I made cut, there was free floating silicone literally pouring out. She bought herself the drain because there was free floating silicone. There is no way that I was going to be able to do in what is the extra capsular rupture, containment, and end block fashion, what is removal of the implant. Now, when I put the drain in, I myself removed it, not the significant other. I myself was very much involved, and I managed that patient from start to finish. So now the drain becomes mandatory. So conversely, I asked the many other surgeons, why do you put drains? Because the burden's not on me why I'm not using them. The burden's on them as to why they're using it. Why are they rushing through the surgery and causing unnecessary irregular bleeding, because the blood loss should be minimal? Why are they leaving the capsule behind and cauterizing the capsule, and now the drains become mandatory? Why are they leaving the silicone spill into the chest and saying it's an end block or a total capsulectomy is done. And now that patient, it's mandatory to get a drain, and not for 1, 2, 3 days, but 1, 2, 3 weeks, which is, if you ask me, that in itself is danger, because the drains themselves stimulate some fluid formation. So in my practice, very professionally, I say, why are you using the drains? Because they're not required, and this has been proven in well over thousands of patients that I've done where the drains are not required. Show me the video and the high definition videos of the chest wall showing no capsule, no silicone spill into the chest with that integrity and confidence and respect, and you will see the drains are not required, because it is a 4-hour surgery. This is a surgery about not speed, about precision. This surgery is all about calculation. This surgery is all about assuming the worst, that the implant is ruptured. This surgery is all about that meticulous millimeter by millimeter dissection. And I'll tell you, it is a hard surgery. One of my other surgeon colleagues, he came into my operating room and he saw me operate and doing the end block, and he said, well, this is so meticulous, this is so involved, I would never do something like this because it's so tedious. And yes, it is mentally, physically draining. If you can imagine, you have to color a 8.5 by 11 piece of paper very nicely, meticulously, such that you all color it with blank ink. You can imagine once you get done, you feel like absorbed and you feel like exhausted. That's exactly how I feel when I come out of the surgery, because it's a very meticulous surgery directly on top of the rib. And this is a surgery where, if you ask 10 plastic surgeons, like I said earlier, 9 out of 10, if not all 10, would feel uncomfortable operating directly on top of the rib. And this surgery is all about removing it all bad inflamed tissue, not only the capsule, but that inflamed tissue that's in the periphery, so that there is no requirement for the drain. And once this surgery is done, clearly you will see the drain requirement is not there, because this surgery can be done, and I've presented it. And now, believe it or not, I was doing the research online, PubMed. I saw another surgeon post, well, the drains are not required for the surgery, and certainly the other surgeons are catching on. Unfortunately, with all due respect to my colleagues, and this is what I said in my last symposium, majority of the plastic surgeons, unfortunately, are fixated on the lift, the aesthetics, the fat grafting done in 2.5 hours, and where that meticulous dissection and careful dissection is not done, where all of the inflamed tissue is not completely sincerely removed, and now the patients are continuing to hurt, but they look good. And unfortunately, that is not the surgery that I offer my patients. I offer them the absolute complete removal, and at the same time absolutely making sure, just like that 85-year-old patient, I went out of my way to make sure that she would look aesthetically very pleasing and very good, and that the symmetry is maintained and achieved at the end of my explant, such that the patients do not need that unnecessary lift. So what I'm going to do is please continue to watch. I hope to do Facebook Live every week so that we can learn from the patients. I have another patient of mine. She's almost a year out from her explant, and we will hear directly from her. Again, long-term stories from my many patients, because remember, well over 90% of the patients, anecdotally, I find have sought relief from explanting, and this is certainly a surgery where once you have a defined problem and you have a defined surgery, and your expectations are very much real. I am very much hands-on involved, talking to my patients before surgery, around and during the time of the surgery, and thereafter. I manage all my patients, and as you will see, this surgery is not about the numbers. It's all about how I'm managing each one. At any given week, I operate on 6 patients or so per week, and so this is a very healthy number, if you ask me, given the nature and intensity of the surgery, so all the patients benefit from what is the perfect explant that I can offer each one of them as they come to me one by one. Any other questions, please?
No, we are all set.
All right, so having said this, please continue to watch. If you have any questions, I just want to emphasize one thing, and I'll end with this. The patients are all very nice. They're learning. Initially, you will be overwhelmed because there's a lot going on. There is, if you go back into December, and Mar, we will go ahead and do this for the new members. There is a list of questions, common questions to ask Dr. Khan, explant surgery, or any plastic surgeon. So you want to get your questions answered. There is a Facebook Live I did in December of 2024 where I answered each one of those questions. You want to take those questions and ask your surgeon directly. You want to be able to feel comfortable. Sometimes some surgeons go in and 4 or 5 minutes later, they're like, it's time for me to move on, because no, you do not want to be rushing through the surgery. You want to be talking to the surgeon directly. You want to get that respect and that confidence so that when you go in to see the surgeon, you have that utmost confidence and peace of mind that your surgeon is listening to you. Your surgeon is not putting in implants ideally. Your surgeon has a track record on social media that she is doing it, I use the word, perfectly right, and that there is no financial disclosure. I want to mention there is only one practice that I have, which is mine, which is removal of the implant. I do not have another colleague who's implanting and augmenting, and I'm selling myself better by saying I'm the only explant surgeon. No. So you have to be very careful. Within a practice, you will find under the umbrella of the same roof, you will find another surgeon who's basically only explanting because he's more marketable that way, and then 3 other surgeons who are augmenting like crazy because they do not want to be scaring away their explant patients. And the bottom line here is you want to do your homework, you want to do your research. You do not want to be under the influence of another counselor or someone who a plastic surgeon has hired in order to influence another patient to come in because they were so good here, or they wrote a book, or they did this or did what. You want to talk to the surgeon directly. You want to see their presence. You do not want to go and be convinced otherwise, other than talking to the surgeon's previous patients and getting that peace of mind and comfort that the surgeon is genuinely interested. I have no financial disclosures. I have no financial commitments with anyone. My only financial commitment is to the patient, so that once you come to me, you get whatever you see on social media, the complete transparency, whatever you signed up for, so that when you ultimately go back to your lives, to your jobs, to your families, you have that peace of mind that all of that tissue was removed, i.e. the implant capsule and all inflamed tissue, and the explant done in the en bloc fashion, our 100% whole capsulectomy. And number 2, all what was removed was tested, so that you have no surprises awaiting you. Thank you very much. Take care, and I look forward to talking to you again very soon on the next Facebook Live.